Okay, well, welcome to our first live case. We'll be going to Dr. Schilling in a moment. But first, let me introduce my panelists. We've got Professor Deutschaver, who was the chair of our last session. And the new faces on your screen are Dr. Syed Hassan, who's a consultant cardiologist at Barts in London, and Afsal Sohaib, who is a consultant cardiologist also at Barts in London. So I think perhaps you can introduce yourselves to the audience while we're getting ready to move to Richard's case.
Hey guys, can you hear me okay?
Fine.
Can you guys?
We can hear you.
Okay, great. So, welcome to OneWelbeck Heart Health in London. Let me just quickly talk you through what we've got here. So this is a multi-use theatre. We're going to use a mobile C-arm to provide the limited X-ray we need. We have a Bard EP system and a Boston Cryo system all set up. We have two saline bags on pressure, so we're not going to use pressure transducers. We'll just use pressure bags to flush the various catheters. And I haven't done anything yet apart from prepare the equipment because I know that many of the audience may be trainees or beginners, so I wanted to talk you through the whole procedure from start to finish and some of the tips or tricks we might use. So the first step we're going to do is to prep the Boston balloon, and I'm showing you this because it's slightly different from the Medtronic in that the balloon material is slightly softer, and so they recommend that you have the balloon inflated to release some bubbles. So Gary, if you just tip the, and then I'm going to activate the foot pedal, so I can do all of this with the foot pedal. And then I'm just going to inflate the balloon, and I don't know whether you'll be able to see this on the camera, but a few little bubbles come off that balloon as it inflates. And then we're just going to deflate that. And it's all ready to go. I'm just going to put the protective sleeve over, and then just pop this out of the way so it's not going to interfere with what we're doing next. So now, if we can switch to the ultrasound, that would be great. So I use ultrasound to gain venous access, and there's quite a lot of data that suggests that that is going to reduce our femoral complication rate. And bearing in mind that this patient's going to go home tonight, we want to make sure that their femoral heals as quickly as possible. I put quite a lot of local around the groin, really to prepare for the Z suture, which we're going to use at the end. Now on the TUE, we can see that the vein will crush easily and is medial to the artery. And I make the puncture injecting a little bit of the local as I go so that I can see where the needle is. And you can see I'm a little bit medial, so I'm moving, sorry, a little bit lateral. I'm a bit close to the artery, so I've moved a little bit more medial. And I've just taken once I start pressing the balloon, once I start pressing the vein, I take the ultrasound away and just use my hand to just get through the final bit. So once I start compressing the vein, I just prepare by moving my left hand onto there. I've got one guide wire in, and I'm going to put the second guide wire in just a second. I'm just going to make an incision for the cryo sheath, which is a bit bigger. I know roughly where I want to go because I've already put one wire in, so I'm going to, can I have the other wire, please, Gary? And where's my, there we go, that one there. So this is the second longer guide wire. So the first wire is just for the 7 French sheath and is really just to allow us to pace the phrenic nerve. So we've got our second wire in, and Angelique is all ready to grab the ultrasound probe, which we no longer need. So Angelique is asking me to do the checklist because she has 4 checklists that we have to do during the case to make sure I don't forget anything. You go ahead then.
Before sheath insertion checklist, capnography reading.
Yep.
SATS monitors reading and audible.
Yep.
There's no thrombus in the LA.
So we've just confirmed that we have capnography and SATs audible. So the saturation beep is my early warning system if the blood pressure goes down and will give me an early warning of tamponade. So if I don't hear that beep, subconsciously I can't help but start getting twitchy and wondering what's going on and checking the blood pressure and making sure we haven't got an effusion. We've already checked there's no thrombus in the LA, so Sachin, our anaesthetist, has got the hardest job of the day. This is a 39-year-old man with paroxysmal AF, but with a lot of allergies, and so Sachin's had to be pretty careful with his anaesthetic, and he's going to do all the TUE guidance for us. If you lift that up, Gary. So we have, these sheaths have quite a big transition. All of the sheaths have big transitions. So I'm going to get Gary to screw the sheath clockwise while I push it forward. Keep turning that handle for me, Gary. Spin it, drill it in as you can. The other challenge with these sheaths is they have quite a good hydrophilic coating, and so keep drilling as fast as you can. And so they're a bit difficult to grip. But if you're patient and keep drilling as fast as you can, we'll get there. There we go, and that's gone. So you don't have to push so hard, it's just the act of drilling. So now if we go to the TUE screen, what you'll see on the TUE is that Sachin's showing the wire up the SVC. So far we haven't used any X-ray because Sachin can confirm our guide wire is up the SVC. And I'm just passing the sheath up, and we're going to see that sheath just cross there and is now in the SVC. I'm going to pull the guide wire back, and that sheath remains there. And now putting our Brockenborough needle up the sheath. And I know that the Brockenborough needle, this 89 centimeter Brockenborough needle, if I put my needle up to 4 fingers from the arrow of the needle to the hub of the sheath, it will still be well back inside the dilator of the sheath. I'm going to take the stilette out, and I'm going to put the transeptal safe set wire, which we're going to use for this puncture, up. Now the stilette inside the Brockenborough needle is sometimes overlooked, but it's really important because it avoids the inside of the sheath being peeled off by the needle. So you have to put the needle up with that stilette, otherwise there's danger of you peeling off material and then embolizing it into the brain. So now Sachin's going to guide me with the TUE. He's in the bicaval view, and I'm going to drag my sheath and needle back to the septum. And you can see it dragging back. There's a little bit of activity there, still slightly high, and there you can see it drop into the fossa ovalis. So now we know it's at the right height, and Sachin's going to swing over to the 0 view and then just adjust his TUE position to show that I'm right in the bang in the middle. Now this safe set wire is really cool because it's just basically a wire that will go through the septum and then guide the sheath. So Sachin, can we go to the left upper now? So I've felt the wire go through the septum, and Sachin's just going to show us whether that, there you go. If you look on the TUE, just on the right-hand side, you can see the wire moving back and forward in the left upper. So I now know that I've got plenty of margin for error. If I push this sheath too far forward, the guide wire is going to put it into the left upper. Sachin, we'll just come back to the septum again. So now we're going to watch the transition of the needle and the dilator and sheath through the septum. So I'm just gently advancing everything, holding my guide wire still, and you can see the sheath is tenting. So that's the dilator through. And there'll be another tent as I try to get the sheath through. Is that tenting still, Sachin, or is that all good? Okay, so just pull back a little bit. So I'm now going to confirm that my sheath is really in the left atrium by seeing if Sachin can show a double lumen. I pulled the dilator and the needle back. If you pull back a little bit, I think we're still... You think that's okay? Just pull your transeptal back a little bit, Sachin, and we'll just make sure. Yeah, I think we're okay there. I'm going to pull everything back now. Just swing over to the septum again. Okay. So that's our transeptal puncture done, and you can see the sheath through the septum. Now I'm going to aspirate blood to make sure that we're all good.
Can I do the second checklist?
Yep. Oh, can we give heparin, please? So Angelique has been quite right in reminding me of the second checklist, and I should have already given heparin because I was, as soon as I got the needles in, I was distracted. Yes, please. So by reminding me, she's made sure that we give the heparin, as there's always a danger, particularly in cases like this, that you forget to do something critical.
So the heparin's been given.
So we give them 10,000 of heparin.
The line's flushed and free of air.
They are flushed and free of air. Can we flush the blue, please? What, is that fully open? That's fully open now, and we're going to put the balloon up. So Sachin, if we can go back to the left upper again, please. So the balloon's going up. Just taking my time with this because I don't want to push air up. And then I'm going to advance the orbiter, the polar map out of the balloon. Now, if we can go to the BARD and the TUE. So on the BARD, if we can go to the BARD live screen and the TUE, that'd be great. So on the BARD, you can see there's a signal. I'm just gently advancing the wire and seeing if it goes down the vein. And if you look on the TUE, you can see the wire. I'm moving it back and forward, going in and out of that vein. So I now know that my wire's in the left upper. I'm holding the wire still, and now I'm going to inflate the balloon. I'm using a foot pedal, which is one of the nice things about the Biosense system, the Boston system, sorry. So once you've got the balloon up against the vein, you can just see it on the TUE, but it's pretty difficult because the contrast just blows everything away. So I'm now going to freeze there and watch the signals on the BARD. We can run the X-ray in and have the TUE out now. So it is possible to do the whole case with no X-ray, but it just takes a bit longer because seeing the right pulmonary veins on TUE is pretty challenging. So we're now going to run the X-ray in and do the rest of the case with X-ray. You can see the left upper beginning to delay, and that's it isolated now. So I can mark on the Boston Cryo system, if we can show that. I think the audience would be very grateful if you show as little as my face as possible, to be honest. So on the Boston system, you can see the temperature, which tends to be much lower than the Medtronic. And you can see the point at which we isolated, which I can mark with a green dot using the foot pedal. If we show the BARD live as well as the Boston, on the BARD live, you can now see that there is a ice ball formed on PV34 when they show that one. Show us the BARD again. And that's because I've pulled the wire right back to the balloon, and because it's in contact, it's showing an ice ball, which is another good sign. Now, the X-ray, we're going to use incredibly low doses, and so the X-ray images might be a bit grainy, but we don't need great pictures for this. Excellent. So, while we're waiting, I'm going to put the quad up, the SVC, ready to pace for the right-sided veins. And normally I would have done this with TUE. I just got excited and asked Sachin to take the TUE out. One important point is that we're using a laryngeal mask, so Sachin's happy to put the TUE down beside the laryngeal mask, and that gives him the advantage that he doesn't have to paralyze the patient, so we're never worried about not getting phrenic capture because of paralysis. And it also means the patients have a slightly better experience with the sore throat. You can see we're just below -61. I never let it go to -65 just because then the balloon will deflate at 70. So I'm going to use the X-ray just to get me up the SVC and the BARD signals. Can you just show the, yeah, there's the X-ray on there, and the BARD as well, if possible. Can you show the BARD as well? Okay, so that's up in the SVC. The freezer's finished on the cryo console. Can you paste the quad, please? So while it's warming up, I'm just going to make sure I've got phrenic capture. And that just sometimes involves me fiddling around with the wire a little bit. So on the BARD, you can see we've got a CMAP signal there, which is pretty low amplitude. Depends on the patient and the positioning of the electrode. But what we're going to show you is the diaphragmatic movement sensor on the BARD. So we can stop the pacing there. And we will turn the diaphragmatic movement sensor, which is basically a accelerometer on the chest, which will show you the diaphragm movement in a more objective way. So while we've been doing that, I've straightened up my cryo sheath and I've pulled the balloon back into the sheath. And then if we can have the camera on my hands, what I'm going to do is just turn, while the sheath is still straight, I'm just going to turn the kit so it's pointing towards the right lower would be. And if you look at the BARD as well, so leave the BARD on all the time. I'm making these guys work hard. I'm putting a bit of bend on the sheath. So I've got a bit of a signal there, and I'm gently advancing the wire out and seeing if it goes anywhere. And if it doesn't, then I'm going to just put a little bit of more bend and then advance the wire again and see if it goes down a vein, which will show by the signal disappearing like it has there. And then on the X-ray, I'm just going to check where it's gone. So it's the right upper, probably. So I'm going to take my sheath back and put a bit more bend on it and see if I can flick it into the lower. So I think that wire is now down the lower. It's the middle branch of the lower. My sheath is just at the nose of the, oh, sorry, X-ray on, sorry, on. Don't bother with my hands anymore, just show the X-ray. And the BARD, yeah, that's perfect. So my sheath tip is just at the beginning of the right lower. And so I'm going to pull the sheath back over the balloon rather than push the balloon right down that vein. If you look at the BARD, my wire has come back into the balloon a little bit, so I've just pushed it out. That's why you had that noise. And I'm just going to inflate the balloon. Now, sometimes you see the signal get bigger because the balloon has popped out of the vein. So let's see on the X-ray where that is. So Gary, can I get you to put some contrast in? So Gary's going to put a bit of contrast in, and then stop. There's just a bit of air coming in there. So let me just... we just saw a little bit of a tiny bubble going in, so I just want to make sure I don't allow that to... Okay. That should be all right. Let's just... Great, so we've put a bit of contrast down, and then I'm only going to take the look once we've finished injecting, because I want to see whether that vein's holding up. Now, the thing about the Boston system is that the balloon is nice and soft, so you don't have to push that hard to get occlusion. It's just about lining it up properly. On that first injection, it wasn't lined up, and so you didn't see dye hang up. So Gary's going to put a little bit more dye in. That's great. And I think I can see a vein shadowing there. We only put like 1 mil in, so let's go with that. Can you pace, please? The quad's quite low, but it's above the PV, so I'm going to accept it for this one, but I'm probably going to have to move it up a bit to do the right upper. We started the freeze, and we're just getting intermittent capture there, so I'm just adjusting the CS, the quad wire position, and it's just related to respiration. We're getting a nice ball forming on the wire because the wire's right back. So I think I'm going to stop there and just reposition this quad in a slightly better position so it's a bit more consistent on the pacing. So I'm going to move it up the SVC a little bit more so it's a bit less prone to cardiac movement, and then have another go with that. You'll have to really shout at me if you want me to hear you, because I can't. I've got an earplug in my ear. That's okay. Yeah. Okay, that looks a bit more stable. Let's inflate again. So the great thing is I've got control with the pedals. Gary, do you want to smash a bit of contrast in there, and then let's have a look. Great. Okay, there's dye hang up again. Freezing again on the right lower. Now, I do the right lower first because it's less likely to ping the phrenic nerve. And of course, if you do the phrenic nerve, you can't do the ipsilateral vein. So I do the right lower first because if we do knock the vein, then it's more likely that the right upper will do that. So we're getting a good temperature. There's still quite a lot of signal there. So for me, the PV signal offers some really important clues. The first is that it tells me I haven't already treated that vein, because if I'm in the same vein and I've already treated it, then I wouldn't see signals. And the second thing it does is tell me whether I'm too far in the vein. So if I don't get a signal, then that tells me that I'm, far away.
So Richard, we have a couple of questions from the audience, if you've got a second.
Yeah, go for it.
One of them is, how many cases have you done with this cryo system as opposed to the Medtronic system, and do you find that there are differences in the outcomes between the two?
So I think I've done about 50 cases with this system. I have not noticed a significant difference in the outcomes, no.
And another question was why you choose to use the TOE instead of intracardiac ultrasound?
Money. So TOE is basically free and ICE is not. And also at the Welbeck, we're able to do all of our cases under GA, and we have fabulous anaesthetists. So why wouldn't we use them rather than me have to try and fiddle around with an ICE catheter?
Makes sense.
So the temperatures are down at minus 57, and yet we've still got signal, but ice ball on PV12, but a signal on 3.4. I suspect 3.4 is actually hanging out because the electrodes 7, 8, and 5, 6, if we look on the X-ray, can we just show that X-ray still for a minute? I'll wait until the X-ray comes up and then we'll show you that position. So the DMS is, so here we can see on the X-ray 7, 8, 5, 6 are in the vein, 3, 4 is probably hanging out, and 1, 2 is touching the balloon, which is why it's got the ice ball. DMS was complaining a little bit, but it was still around 80% of where we started. So the diaphragmatic movement was still about 80% of where we started, and we got down to minus 60. So I'm going to say that I'm happy that this vein either didn't have signal in it, or we've done an adequate freeze there, both because of temperature and dye hang-up. If you look at the X-ray system, you can just see a tiny little bit of dye down that vein. So I'm going to accept that rather than pursue that and switch to the right upper. Sometimes the right lower doesn't really have much signal down it at all. Can we stop pacing, please? So the balloon's rewarming, and once it has warmed, I've straightened up the sheath. I've pulled the balloon back into the sheath, and then I'm going to put a tiny bit of bend on the sheath to point me to the right upper. And then I'm going to advance the guide wire out. You can see the wire's got signal on it on the bard, so it's come out of the right lower. And then I've advanced it, and it's gone up something. The question is it up the right upper or up the right lower? So I'm going to do a quick shot, and it's down the right lower again, I think. So I'm going to straighten up the sheath a little bit more and pull it back a little bit, and then see whether I can get this wire up a different vein. And that's gone up the right upper now. So that was just a case of pulling the sheath back a little bit, turning it a bit more clockwise so it's pointing more anterior, which is where the right upper is generally, and then advancing the wire back up again. I've advanced the balloon out, and I'm going to inflate it before I do any X-ray. And then, Gary, do you mind just popping a bit of dye in? Just 2 mils. That's great. And then we're going to take a look. So it's not occluding, but it's in up against the vein. Now, with this system, pushing doesn't help. You've got to line it up properly. So I'm putting more bend on the sheath, because if I push the sheath, it will just push it up towards the left upper. Try again there now, Gary. It's just a case of getting the sheath lined up. That's great. Still not as I would like it, so I'm just going to put a little bit more pressure on, another injection there. That's great. I'm working Gary hard here now, because he normally expects the balloon to be occluded now, so I feel the pressure. Okay, I've just made another adjustment with the sheath, and that's still not working. Try now, Gary. There you go. Now we've got occlusion. I just pushed the balloon out of the sheath a little bit just to launch it up. Quad is still above the PV. I'm pulling the wire back a little bit just to show a better signal. And we're going to pace, and we're going to freeze. So let's go to the cryo console instead of X-ray just for a second. So what you can see is on the bottom left-hand corner, we've got the diaphragmatic movement at 100% at the moment. So that's the equivalent of me putting my hand on the abdomen. The temperature is dropping well. We're below minus 27 already. And the vein's isolated. So I'm marking that with my pedal. And now I'm going to keep a really close eye on that diaphragm, because it's the right upper that can be a problem. And you can see that the balloon is aligned with that phrenic nerve. You know, if your balloon is at the heart border, then that's a danger sign that you need to be careful. Far away.
Some tips. You very nicely maneuvered the balloon from the left PVs to the right. Can you give us some tips and tricks for those challenging right lower veins in particular? when you're struggling to make good contact inside that vein? What you do in that situation?
So with the Boston, I put full bend on to try and line it up. And if that doesn't work, I then X-ray while I'm pushing dye in just to see whether the leak is at the bottom or the top. If it's on the side, I'll try and turn the sheath clockwise or anti-clockwise. And if that doesn't work, then I'll push the balloon in a little bit so the top's in contact, freeze, and then pull the rig down to close off the bottom end. With the Medtronic, you can get away with not necessarily occluding the vessel, the vein, because the balloon gets a little bit bigger. So I don't necessarily go for occlusion in the Medtronic if it's very difficult. I'll just accept it looks like the dye is hanging up a bit and hope that when the balloon gets a bit bigger, it blocks it.
Great, thank you.
So we're down to minus 63 on the cryo console. The diaphragmatic movement's still okay, but I'm not going to let it get any lower than that. So I think I'm going to stop there. So I've pressed the stop button on my pedal. We got to 150, but we had a really good temperature drop, and we are well out from the point of isolation. And I don't do bonus freezes because my feeling is I'd rather fail than cause a complication. So I don't do any bonus freezes if I get a good isolation. So now we've got one vein to go, which is the left lower. In preparation, I'm just going to straighten the sheath while the balloon's warming up. And my plan is to turn the sheath clockwise away from the valve, around the back wall, towards the left upper, get the wire up the left upper, and then get the sheath to the mouth of the left upper. Can we have X-ray on there, please, guys? And then turn the sheath, bend the sheath a little bit and turn it clockwise a bit, and it'll point towards the left lower. Now, sometimes the natural bend on the wire will put it down the left lower. So I'm just advancing the wire out. So I'm going to pull the balloon back into the sheath. I can see that the wires come out of the vein on the bard. I'm going to advance the wire up, and that's gone somewhere. So I'm going to advance everything, the balloon out a little bit as well, and we'll see whether that wire's going down towards the lower. Now, I'm going to just advance this wire a bit more. So I think that's the lower. Now, the question is, was this the vein I did at the very beginning? Because it had a little bit of an inferior bend on it. So I'm going to pull the wire back to the beginning, and I'm not convinced there was a big signal there before we got the V. So I'm going to have a look and see if there's a separate left upper that's more obvious. So that's definitely the left upper there, because you can see the wire is going horizontally across. And if we look at the PV signals, there may be a PV signal on 3, 4, 5, 6. So indeed, that may be some signal on 1, 2. So I'm going to try inflating the balloon there and occluding that vessel. And then if I can pull the PV back and still have a good signal, then I think that was the one I didn't do before. Okay, Gary, can you inject there? Okay, so as I push the sheath forward, the balloon tends to nose down, so I'm lining it up by deflecting the sheath rather than pushing the balloon forward too much. Let's inject again there. Try again now. So I'm still not convinced I've really blocked that vein, so I'm going to work to try and put a bit more dye in. Now try again now. Keep that syringe pointing upwards, yeah? That's it. I think we've got dye hang up there, so I'm going to freeze there. I'm pretty convinced I've got a signal on 5/6, so I'm pretty convinced that I haven't treated this vessel, this vein.
Richard, is
Go
there any
for
way
it.
to distinguish between the left upper and left lower on the TOE? Do you have any advice for the audience in confirming which of those veins you're in?
So on the TOE, in the zero view, you should be able to see the sort of left upper following parallel to the appendage. The left lower is usually pretty difficult to see on a TOE without sort of quite complex manoeuvres, but it all depends on the anatomy.
Of course.
Right. I was just wondering, did you want to talk through your logic for the order in which you did the veins? Because you started with the left upper and then you went to the right lower, then right upper, then left lower.
Yeah, well, when I say left upper, I do whatever vessel it falls into, which is usually the left upper. Now, I'm getting good temperatures here, but if you look at the barred signal, it's not really changed, it's not delayed. So I think this is a far field appendage. So I think this was the one I did before. So I think I've made a mistake here. Now, some people will go LEO, REO and look at shots that way and do pulmonary vein angiograms, but I'm not sure this takes much more time. So I'm going to switch veins now and go for what I think is now the lower. So I think I've made an error here on the basis that the signals aren't delaying. So my logic is I'll start with one of the left veins. I'll go to the right veins next because I can put the quad up to the SVC while I'm doing the left vein. I don't have to watch it. I don't have to pace. If I do the right veins next, then the last vein I'm doing is another left vein, which I don't have to pace in. So again, once it's isolated and frozen, I can then start taking all the kit out I don't need, and I don't have to worry about the diaphragm. I can start putting the Z suture in. So it just saves me a few seconds during the case. Okay, so let's see if we can get down the true left lower, which should point all the way down like that, down the side of the heart. So this is a different vein, I'm happy. It's difficult to tell from the signals whether you're in a vein or not until you've got the balloon up, because the balloon is what defines the beginning of the vessel. And so I may have been misled into thinking that I didn't have signals in this vessel because I wasn't occluding it yet. Can you just put some dye in? I'm happy this is a different vein, or at least it's a different branch of a vein. Yeah, go for it. Yeah, that's great.
Regarding the negative temperatures and the difference with the Medtronic balloon, what do they mean? And is there any concern regarding efficacy or safety in one of the two systems regarding the negative temperatures you reach?
I think it's just a sensor difference, because if you look at the isolation points, the isolation point is lower on the Boston than it is on the Medtronic, and the absolute temperature it gets down to is lower than the Medtronic. So I think it's just where they've positioned the sensor and the temperature it measures.
So you have no feedback from esophageal temperature probes?
I think that they just give you different. We don't. You mean esophageal temperature probes?
Yeah. Yes.
I don't use them. So I've never used one in cryo.
Okay.
So if you look at the X-ray, you can see that I've got a bit of dye hang up. I've got the wire right back at the balloon, and yet I've got no signal. I'm getting a pretty decent temperature, and there's no change in signal. So I think this may have been a common origin with two branches. If you look at the sort of shadow of the left pulmonary vein, you can see it's a pretty big trunk, and I think I've been down two different branches. The wire, I was happy in this position, went right down the lower, and on the second occasion it went horizontal or into the upper lobe. So I'm happy that we've done this vein. So I think we've done as good a job as we could hope for today. So I'm going to start now putting in the Z suture. while we're finishing off this freeze, the pacing wire can come out. I have not come across a situation very often where I've had to put the wire back in because of vagal. Normally, if you get vagal, it happens on the first left vein freeze, and so if it does happen profoundly, then I'll leave the wire in. But if you've already done a vein and they didn't get a vagal response, then you're usually fine. The Z suture sometimes in big people doesn't stop the bleeding. So this is a suture, one there and then one there, and then because we're mean, I'm going to recycle the 7 French sheath 3-way tap because Gary's too mean to give me a new one, and I'm going to use this to produce the tamponade on the suture. The advantage, so Devi convinced me that this was the way to do this. So Devi, now who we're going to see in a minute, is convinced me this was a good thing, because what you can do is you can loosen it while the patient's recovering, and they can walk around and go to the toilet with the suture hanging off. And if it doesn't work, you can just retighten it. Whereas if you tie a knot, then they can't, it's either there or it's not. So we've completed this left vein freeze. I'm straightening the sheath in preparation for withdrawal from the left atrium. I don't normally make a big effort to straighten and flatten the balloon with the handle here like you do on the Medtronic, because it seems to wrap a little bit better. So that's come into the sheath without any problems. The sheath is coming back. The quad's already out, and Sachin, we can give some protamine, thank you. So now we're going to just push this suture down onto the groin. And Gary's main job here is to make sure that the sheath doesn't flick and upset anyone. And then if we can see the groin there, it doesn't look great, but it really works well. So that's now no bleeding there at all. And we're good to go. Can we just have a quick look at the echo, please, guys? We'll do a quick echo before he leaves the room. And as Jason implied, it's really, really unusual for them to have a late tamponade. So if they don't have it now, I don't bother doing it later on.
It's a really nice case.
And I don't know whether you can see.
Richard,
Yeah, fire away.
yeah, you just a couple of questions. So really nice. Thank you very much. That was very slick. ACTs, you just give 10,000 of heparin at the beginning, and normally that's enough for the whole procedure. Do you ever check the ACTs any sooner?
No. So if we're in a position where we're having to check the ACT, then this technology is not working. So if you're really struggling to occlude a vein and it's going on for a long time, I'll just stop rather than keep pressing on. So we don't use ACT, we just give 10,000, because by the time we've taken it and responded, usually the case is close to the finish anyway.
Sure. And the second question is, can you give us it didn't look like you used very much X-ray. Can you give us an idea of your fluoro time and dose from that case?
What was the dose and fluoro time, Angelique? 3.6 DAP, and the time was 1 minute.
Nice.
And frankly, there's no magic. It's just looking at all the clues, like the clues on the bar. Many people don't bother looking at it, but it gives you a lot of good clues as to where you might be before you have to start shooting the X-ray.
So, Richard, I have a question for you, and I could be a perfect foil for this conversation, since I don't really make any attempts to do low fluoro or no fluoro cases. The thing that struck me most was when you're doing your pull for the transeptal down from the SVC into the atrium. It wasn't clear to me how you how you decided which way you needed to line up to point your needle in the first place. Was that just by looking at its position outside the body and the groin?
Yes. So I've got this. Yeah, good point. So I've got the sidearm of the sheath and the arrow of the needle pointing at about 4 o'clock. So my initial drag down is literally just to get to the right height in the fossa, and then Sachin moves us back to the 0 so that I can see whether I'm actually in the middle of the fossa or whether I need to adjust that angle. So if I'm at 3-4 o'clock, I know I'm going to be roughly okay, somewhere near the septum, and then I can make a final adjustment at the 0 view once I'm at the right level.
Makes sense. And as you switched, Richard, from the dinosaur days of essentially a continuous fluoro video of the case to what you're doing now, can you give us an idea about what the transition was like for you as you were getting comfortable looking less and less at the fluoro?
So I had a period of about 3-4 years ago where I had 2 or 3 tamponades in a year. And at that point, I was pushing it too hard and I was getting too cocky. And the main error I made was that I'd make the transeptal puncture, but then, of course, I'd push the sheath on too far and damage the appendage, which is not easy to see on the TUE. You've got to swing the TUE to a different position. And the thing that made the difference for me was that safe step guide wire, which is the little sharp guide wire you make the initial puncture with, because if that's up the left upper, then even if you advance your sheath a bit too far, it won't hit the appendage because the guide wire will take you into the left upper. And since then, I've had no problems. But it was helpful to have a relationship with 1 or 2 anaesthetists where we got used to one another. And so Sachin now knows exactly what we're looking for and helps me see everything. And if I don't have an anaesthetist I've worked before, I'll use the X-ray just to confirm that I'm not pushing the sheath in too far.
Was there any point when you used pressure recording from the tip of your needle to help convince yourself that you weren't, across the septum, but then up against the posterior wall or the appendage or what have you?
Yeah, so I used to use it with the Endries needle, but since I've been using the safe step guide wire, I don't use it because you could connect it in theory, but it would be pretty damped off. And as long as I can feel the guide wires moving easily back and forward within the sheath, I know that the guide wire is not being sort of pressed up against the roof and kinked with the sheath. So, I'm also just checking the wires sliding back and forward easily, and the sheath and dilator are being guided over it, the same way as you would if you're pushing it into a difficult, tough groin.
Got it.
Richard, I think you did an exceptional case in 45 minutes in a live audience while talking. You isolated 4 veins. So a very honest live presentation. I'm just thinking what is new here in this live case, because it looks like many of your procedures you've done live. So I want to go back to the Boston balloon. How is it different from the other procedures you performed? What is the advantage and disadvantage? I want to know the comparison to the prior balloons.
Okay, well, look, let me tell you 2 things that are new. Firstly, everyone in the lab, put your hands up if 6 months ago you'd ever seen an EP case or done an ablation. So there's the ODP has done some ablation, our X-ray person, but our nurses and our physiologists have never done an ablation before 6 months. Okay. So the first thing that's new is repeating the process over and over again means that they are really good. You could see I wasn't asking them for anything. They knew exactly what I needed. So they've just got good at doing the same procedure over and over again. With the Boston, it's a slightly different technique from the Medtronic in that you don't have to, if you push it, it'll just prolapse away because it's quite a soft sheath. But the balloon is also quite soft, so it tends to accommodate the vein much more easily. And so you don't have to push as hard. The Medtronic, you can get away with pushing it harder because it's a stiffer sheath and a stiffer shaft of the balloon. but you have to push it hard to get it to accommodate to the well, you have to make the vein accommodate to the balloon, and with the Boston, the balloon tends to accommodate the vein a little bit better. It's also pretty interesting using the foot pedal, because again, you're not having to shout at everyone, come on, come off. And so that's quite a nice feature to have control over that. But the only problem with that is you have to keep telling people what you're doing, because you could do the whole case and not say a damn word to anyone, and then they lose track of where you're at with the procedure.
What is the lower end of the minimizing fluoroscopy? Because I think I remember you saying that all this minimizing X-ray is a kind of macho behavior. Look how good we are. I think it were your words in the symposium. So what do you think is the lower threshold? Because there is also a certain safety factor in fluoroscopy you will never want to give away. Am I correct?
Yeah, and I think that, you know, fluoroscopy is a really important safety feature. So when we're doing our simulations of tamponade, particularly if we're using 3D mapping systems, it's really important that we do that, because people forgot to actually have leads in the room. Because if you have a tamponade, you want a lead on so that you can drain it. As I said, 3 or 4 years ago, I think I got excessively macho and I made some mistakes and caused some tamponades as a result. So if there's any doubt, I'll do an X-ray. I'll shoot an X-ray just to make sure where I am. So I would not do this procedure without a fluoroscopy machine in the room, particularly as I know here at Welbeck, we have no overnight beds, we have no surgical cover, and so we've got to make damn sure we do this procedure really, really safely. So I think it's possible to do it 0, and I have done it 0 before, but it's not practically helpful, and the dose difference is so tiny that it's not worth it.
Richard, I have a question for you. With regard to the lack of surgical backup, for example, have you had the experience of any difference between patients who are on a NOAC throughout the case versus those patients that were on Coumadin, say, before the case? And specifically what I'm really after is we've had a handful of cases where we got a pericardial effusion, we got tamponade, and initially we're able to drain fluid easily. And, you know, as you're well aware, often you put a pigtail in, you can drain the fluid, and there's no thoracotomy required. But what we've seen on a number of occasions, and it appears to be with the NOACs, is that eventually the blood clots in the pericardium and you can no longer pull it out via the pigtail, and that necessitates thoracotomy just to pull the clot out. Have you had that experience at all?
I have had colleagues have that experience. My anecdotal experience is that I've not seen it noticeably any more than with Coumadin, but I've definitely had colleagues have to send someone to surgery because they've got a clot in the pericardium that they can't get out. So I think that's an interesting comment. With regard to no surgical cover here, this is our emergency box. So we've got our drain kit here. We've got a laminated checklist and safety sheet, and we do a rehearsal. And if we had a tamponade, we would drain it, reverse the anticoagulants, and we know that the ambulance can get the patient to a cardiac center within 15 minutes, which is pretty much the same as it would take to get them to a theater. So we're pretty comfortable, particularly in the COVID era, that this is a great option for patients, because it's very difficult for them to get into inpatient beds at the moment.
Yeah, so
just checking.
we have a poll for the audience that I believe will come up on the screen for you, and if you could take a moment to answer that poll, we get a feel for what folks are doing out there with regard to minimizing X-ray.
So while that poll's running, I've just checked his groin. He's sitting up at 30 degrees, and that suture is rock solid. I don't know why it works, but it seems to.
How long do
And
you
if the
leave
audience can hear
Z
snoring,
suture?
that's not the... If the audience can hear snoring, that's not the staff, that's the patient. Okay.
Richard, how long do you leave the Z suture in for typically? What's the normal practice?
So, I'm looking for help from my nurses because actually they're getting much better at than managing me. We usually leave about an hour and a half to 2 hours, and then we'll make sure that they can go to the toilet and walk up and down the corridor before they go home. So they're generally home in about 3.5 to 4 hours.
Great.
Richard, there was a audience member that asked what a bonus freeze is.
Bonus freezer, sorry. So what we used to do, and some centres still do it, is to give an extra freeze after you've isolated the vein in the hope that that will reduce the recurrence. I've now not stopped doing that some years ago because I think if you get a good freeze and an early isolation, I'm not sure a bonus freeze makes any difference. We're increasingly seeing patients come back with paroxysmal AF with all veins isolated. And I think the disadvantage of a bonus freeze is it probably increases the chance of pulmonary damage and side effects and increases the risk of phrenic nerve problems. About 1 in 100 patients, you see vagal nerve problems. They get delayed gastric emptying, which is really, really unpleasant for the patient. Usually it will get better within a few weeks, but I've had one patient where it's taken 4 months to start getting better, and they were pretty thin to start with, so it was a pretty unpleasant period. So for me, if I've isolated the vein, I'm happy.
Got it.
Richard, you have that device which gives you some feedback on phrenic capture, and you were talking through some of the percentages you saw during the case. Do you just want to sort of go through that, because that's probably unfamiliar to a lot of the audience?
Yeah, I'm just seeing if I can find the... So if you can... I'll just show you this here. So this is the DMS, which is basically just an accelerometer that you clip on an ECG sticker on the chest, and it just measures how much twitch there is in a more objective way than you would with just putting your hand there. And it will calibrate at the beginning of the freeze, and so it starts at 100%. And if you get below 80% movement, then it's probably sensible to stop freezing. So it's quite sensitive, and it takes a little bit of getting used to, but I've now got used to it, and I tend to look at that more than the CMAP, and I find that a little bit more easy to read. And if it goes below 80%, it starts flashing red at you, so it warns you that things are not as they should be.
From one of the audience members about whether, if you get phrenic injury during freeze of one of the veins, whether you continue with freeze of the other veins subsequently.
Not on the same side, no. So that's why I do the right lower first, because there's a lower chance of me damaging the phrenic with that. But if I do ping it with the right lower, I won't do the right upper. I'll bring it back for another day with a different technology. All right, Nick? All good. Everything went really well. All perfect. Yeah. Yeah. So you guys going to go on to the next presentations a bit early, or how do you want to play this?
For technical reasons, I'm not able to see the response of the audience poll, but if there's anybody else who can, perhaps we could report the results before we move on. So 41% said optimize X-ray dose. 22% transesophageal echo. And 18% said I don't do cryoablation.
Okay.
Yeah, so optimizing dose of the X-ray is the winner. And I can tell you that I personally use the stick my head in the sand method and hope for not getting cancer.
Well, one day, Peter, I'm going to hope to
Okay.
convince you to do cryoablation, but I think it's going to be a cold day in hell, isn't it?
Yeah, I think so. So I think it's time for us to move on to the next session. But Richard, thank you very much. That was a superbly done job, and you've succeeded in making at least me feel bad about my own technique.
And thanks to the Welbeck team.
Thank you.
Thank you.
Yeah, and absolutely. I'd like to thank everybody on the panel. It's been very helpful to have your questions and elucidate what's been going on. We'll see you later.